Good evening, everyone, and welcome to Anime Talks, where we feature the leading physicians and experts in African American health. This program is specifically designed for a non medical audience and is brought to you by the National Medical Association, the collective voice of African American physicians, and the leading force for parity and justice in medicine. Be sure to like and share this video. We have an exciting program tonight with focus on COVID-19, heart health, and the African American community. I'm your host, Dr. Michael G. Knight. You can find me at the District Doc on Instagram and Facebook. I'm a board-certified internal medicine and obesity medicine physician and assistant professor of medicine at the George Washington University here in Washington, D.C. We have an exciting panel tonight. I'm going to go around and do my introductions. We have Dr. Mary Branch, who is a cardiology fellow at Wake Forest University with an interest in cardiac disease related to chemotherapy in cancer patients. She is originally from Youngstown, Ohio, and her hobbies include community outreach and advocacy through writing, family genealogy, running, and reading. She is a member of the Association of Black Cardiologists, the American Heart Association, of course, the National Medical Association, and the Links Incorporated. Welcome, Dr. Branch. Next, we have Dr. Ilanze, who is an assistant professor of medicine in the section of advanced heart failure and transplant cardiology at Indiana University School of Medicine in Indianapolis, Indiana. And you can find him on Twitter at @HeartDoc and also at LinkedIn. He's a certified specialist in advanced heart failure and transplant cardiology with a special interest in studying the effects of COVID-19 infection and immunomodulatory responses in heart transplant recipients, heart failure with preserved ejection fraction, and sickle cell cardiomyopathy. Welcome, Dr. Ilanze.
Thank you.
Dr. Ayinde is a board-certified cardiac electrophysiologist at Novant Heart and Vascular Institute in Charlotte, North Carolina. Dr. Ayinde has a very strong interest in reducing healthcare disparities, mentoring, and increasing access to healthcare among minorities. He serves as assistant chair of the cardiology subsection of the National Medical Association and mentors many minority physicians through the Association of Black Cardiologists.
Mm-hmm. Thank you.
And last but not least, we have Dr. Wallace Johnson, who practices medicine at the University of Maryland School of Medicine as an assistant professor with a special interest in hypertension. As a certified specialist in hypertension, his special interests are hypertension in special populations like African Americans, community outreach, student mentoring, and teaching preventive cardiology. Dr. Johnson is the author of a book as a published researcher, and he's also the medical director for the Aortic Center at the University of Maryland. He's a chair of the cardiology hypertension section of the National Medical Association and a former president for Baltimore's Monumental City Medical Society. Welcome, Dr. Johnson.
Thank you.
All right, we've gotten our introductions done. Let's jump right into the program. When we think about cardiovascular health, we know that cardiovascular disease affects the African American community at a much higher rate, unfortunately, than the majority counterparts in the United States. We know that in 2017, African Americans were 20% more likely to die from heart disease than non-Hispanic whites. We also know that African American women are 60% more likely to have high blood pressure as compared to non-Hispanic white women. And finally, although African American adults are 40% more likely to have high blood pressure, they are less likely than their non-Hispanic white counterparts to have their blood pressure under control. So when we talk about cardiovascular health, we're talking about heart health, we're talking about heart failure, heart attacks, blood pressure, strokes, all of that's involved in the cardiovascular system. And so we're going to talk to this panel of experts in heart health in the African American community. Why don't we start off with Dr. Johnson? I'm going to bring you in right here. Can you talk about the impact of cardiovascular disease on the African American community? You know, we just heard some of these statistics. Why is there such a high burden of disease in our community?
Well, there are many factors, but I'm just going to kind of concentrate on a few. The first factor that we think about is number one, the grandfather, and of course, you know, you're going to get a bias from me of cardiovascular disease in many situations is going to be what? Hypertension. African Americans, among other Africans of the African diaspora, if you will, people of African descent all over the world, African Americans lead the world above, say, rural Africans and Africans from Africa, and even Africans from the Caribbean. African Americans, unfortunately, lead the way when it comes to hypertension. So there's a natural byproduct of that being cardiovascular disease that occurs as a result of that. The second issue is that we know that there are other factors that come into play, which are not just purely medical, but also environmental. African Americans have traditionally been placed in situations where environmental factors, stress, racism, things of that nature, have an undue burden on this community, on our community, I should say. And in addition to that, we also know that when you are at the lower end, unfortunately, in terms of socioeconomically, having lower socioeconomic status, if you will, we know that often predisposes us to what? Buying foods in places that are not necessarily the healthiest foods. I can remember, for example, in Baltimore City, we went to a particular supermarket that was actually African American owned. And we asked the African American owner of this particular supermarket, why don't you have healthier food products? And one of the problems that we had, unfortunately, was he was stating that many times the healthier food products would have less salt. He would state would perish faster. And he would state that he would have to throw out more healthy foods. And would also say that, unfortunately, many of the patrons had a pattern of course, eating unhealthy for years and years and years. So just because he made healthy foods available did not mean that everybody decided to go in and be faithful servants, if you will, in terms of thinking about how we can go out and be faithful to foods that are healthy to us versus foods which are unhealthy.
Thank you so much, Dr. Johnson. You know, Dr. Branch, one of the things that we saw in 2020 was this reckoning about addressing the effects that racism and discrimination have had on the health of the African American community. Does that play any role in some of these rates, do you think, of cardiovascular disease?
I think it certainly does. And I think the American Heart Association sort of during this pandemic to really recognize that racism is part of the pandemic and has contributed to the pandemic. And in fact, was kind of our COVID-19 before COVID-19. So certainly it's contributing. You know, folks, we know that there's studies where folks present to the ED with chest pain, and there was a big study that depending on your race, you were more likely to go to the cath lab or not if you had typical chest pain. So, you know, knowing these statistics, knowing that, you know, folks may not be believed, that may limit folks going to the hospital. Now you have on top of that a pandemic with COVID-19, which certainly you know, make folks even more hesitant to come to the emergency room and saying they're having chest pain. So sort of anecdotally, I can't necessarily say by race, but we were seeing a lot of folks sort of in March who were coming in a lot later with, you know, days and days of typical chest pain. And unfortunately, some of these people went into deadly arrhythmias and ended up dying on the cath table trying to get a heart catheterization. So who knows if, you know, African Americans may have even stayed home because we didn't even see them, you know, with these symptoms. So you have before COVID-19 hesitation about being believed with heart disease, especially in women. And then now you have a pandemic and a virus in which people are trying to avoid the emergency room. So it's just a double pandemic that we're dealing with.
Thank you, Dr. Branch. You know, you talk about the connection with COVID-19. I want to bring in Dr. Alonze right here because I know you've done some work in this area. When COVID-19 affected our country, initially everyone said it would be the great equalizer. But as we know, that didn't end up being the case, where we saw very rapidly that there was a disproportionate effect in the African American community. When we think about the effect that COVID-19, as well as cardiovascular disease, we started seeing data talking about myocarditis, which is an inflammation in the tissue around the heart. What is the connection between COVID-19 and cardiovascular disease?
Yeah, so that's a really interesting question that has really held us captive for the past 12 months. So when you think of COVID-19 and cardiovascular disease, there's sort of three levels to think about it. The first level is in a patient who has acute COVID-19 and who's hospitalized. We found out early in the pandemic from China that they had very high levels of biomarkers like troponin and the BNP. And that if you had those high levels, that they were likely to do worse and likely to even die in the hospital than people who did not have who had COVID-19 without high biomarkers. But acute myocarditis has never really been confirmed on the basis of the actual criteria for the diagnosis. Now, shortly after that, there were two very concerning reports from Germany where they found that people who had acute COVID-19, actually, when they had MRIs done, found out that they had low ejection fraction and sort of signs of heart dysfunction on those MRI done. And more worryingly, there was also data of autopsy data of people who had died from COVID-19 and showed that there was evidence of the viral particle on autopsy samples of those people who had died. So the short form is, if you have COVID-19 and you're acutely in the hospital and you have high biomarkers, you're more likely to do worse. Now, for the asymptomatic person at home who tests positive for COVID, the nice thing is we don't have any evidence so far that there's actually going to be damage to your heart.
Excellent. Dr. Ayinde, I want to bring you in here because as was just outlined, there was a lot of data coming out about individuals with COVID-19 and having presentation of some effects on the heart. When we think about individuals who overcame COVID, so they had an infection, they survived, they went back to being living their normal life, did we see information about heart effects that were happening later down the line? Is this a concern for individuals who have been infected by COVID-19 in the past?
So we still don't know. There was a study that looked at people after 6 months in China and found that they still had some kind of symptoms, namely mostly fatigue or exercise intolerance. But there's been no solid data that tells us what the long-term consequences on the heart are. Now, empirically, what I've seen is I've seen a lot of patients coming with, just saying, after my COVID infection, I can't do the things I used to be able to do. I used to walk 5 miles and now I just can't do 2 miles. So I think a few people recover with a reduced function. More importantly, I think what may be something to look at will be what is the opportunity cost of COVID on other heart diseases. I think that may be a more important thing. For example, people who present late, people who have chest pain who didn't go to the hospital early, people who have abnormal heart rhythms who don't get it taken care of. I had a patient recently who has an abnormal heart rhythm. She needs a pacemaker. And she told me, I don't want to catch COVID, so I'm not going to go to the hospital. So she's going to wait it out, and she's at risk of dying from the abnormal heart rhythm, but she doesn't want to catch COVID. So I think more importantly will be the opportunity cost and the things, the unintended causes of COVID on the heart may actually be bigger long-term than the long-term effects of COVID itself on the heart.
Thank you for that. And I think the point that you made about the delays in care. As an internal medicine physician, we definitely saw delayed presentation or delayed arrival of patients to seek emergency care. Whereas before COVID-19, that having chest pain or stroke symptoms, weakness on the side of the body, and individuals were, calling the ambulance and getting to the emergency room. And now, as you've outlined, people are waiting at home. Maybe I'll take my chances because it seems like COVID-19 is in the emergency room. When we think about some of the early information that was here. Another thing, I wouldn't say delay of care, but what I found was initially there was a blood pressure medication that was initially said that may have been linked to risk for COVID-19 infection. I'm going to bring you in here, Dr. Johnson. And so when I had patients who came to me and said, Dr. Knight, I stopped taking my losartan, for example, is an example of this type of blood pressure medication. And now the blood pressure is sky high. And I said, well, why did you stop it? And they said, well, I saw on the news that COVID-19 risk was linked to my blood pressure medication. Dr. Johnson, tell us a little bit about that. What was that all about, and what have we learned from that? You're muted.
Can everyone hear me now?
Yes, go ahead.
Okay, just want to be sure. It was unfortunately a complicated and unfortunate story, meaning that the angiotensin converting enzyme, by the way, the drugs we talk about, like lisinopril, for example, is an ACE inhibitor. And then the drug you just mentioned, losartan, is an angiotensin receptor blocker, two of the more prominent and commonly used drugs for hypertension in the United States as well as abroad, for that matter. But the point I'm trying to get at is the angiotensin converting enzyme 2, if you will, the ACE2, if you will, was found to be implicated in allowing the virus to get into cells, the COVID virus to get into cells. So people said, well, maybe if you have a drug which somehow affects this angiotensin converting enzyme or touches on that receptor, maybe that's going to make it easier for the COVID virus to get into the cell. Now, what wound up happening after that, fortunately for us, we got more data. And as more data came in, the data became more and more conflicting. But here's a few quick take-home points I want everybody to go home with. One, there was a study where they looked at the COVID, if you will, infectivity and the impact of COVID, and compared it to, say, for example, one group of patients who would take drugs like lisinopril and losartan, and another group of people who took, say, another group of anti-high blood pressure or high blood pressure drugs, if you will, found really overall no difference. Second important point to keep in mind, a lot of this initial data became, from not surprisingly, animal studies. But even in the animal studies, the data was conflicted about whether or not the COVID susceptibility was increased susceptibility to COVID, secondary to the fact that you were taking a drug like a lisinopril or losartan. So the take-home message has to be, one, there was conflicting data, but two, more importantly, most of the large societies out there in cardiology have all come out against the thought process of stopping your medication because you have or concerned about getting the COVID virus and dying from the COVID virus. You would have a much greater chance of dying from stopping your medication than you would from worrying about catching the COVID virus because of the medication. That's the take-home point for the evening.
Thank you, Dr. Johnson. And so, just you heard it straight from our experts. We want you to talk to your healthcare provider. Don't just stop a medication from what you hear on the news. We want to be specific about what the data is and what's the safest choice for you. Dr. Branch, I want to bring you back in here because another thing that we heard about COVID-19 that was related to the cardiovascular decision was blood clots. And we heard about an increased risk or possible increased risk for blood clots. Can you tell us about that? Was that a real risk, and what should people know?
Yes, there is data to suggest that there is an increase in what we call thrombosis or blood clots in those who have COVID-19. And they even saw it in sort of younger patients than you normally would see strokes. And thrombosis can really affect all of your vasculature. So if you have a clot in your coronary artery, say your left anterior descending, which is a very important artery that supplies a substantial proportion of your heart, then that can cause a heart attack, that can cause a myocardial infarction and lead to heart failure. So that's something really important to note when folks are coming in, that we may see not your typical sort of plaque rupture with atherosclerosis, but there may be sort of thrombosis as well. So that's something certainly to consider. Strokes as well, young folks who come in who may have stroke symptoms and COVID-19, certainly that's not something you want to dismiss because someone doesn't have your typical risk factors of smoking and diabetes. If they do have COVID-19, understand that there is an increased clot risk. So that's something that we're definitely keeping an eye on and something we have seen.
Thank you, Dr. Branch. And for the audience, we will be taking questions. So if you have questions, please go ahead and start putting those in the chat. For our panel, we will try to get to as many questions as possible. So again, if you have questions for our panelists, please put that in the chat. Let's continue the conversation. We talked a little bit about blood clots, strokes. We saw a little bit about heart failure. Dr. Alonze, I have a lot of patients who come to me and I look on their chart and it says heart failure, but I ask them if they have a heart condition and they tell me no. Tell us a little bit about the prevalence or how common heart failure is and what really causes it. And let's hear you.
Yeah, thanks for this is a really important topic that is very near and dear to my heart. Heart failure is a condition whereby the heart is unable to pump enough blood to meet the needs of the body. Heart failure as a condition is actually very common. If you get to the age of 40, your lifetime prevalence of heart failure is 1 in 4. It's primarily a disease of aging. People get it more as they get older. Interestingly, there's data that a lot of people don't know about, which is that if you're of African ancestry, you're likely to get heart failure about a decade earlier than Caucasians. And if you have heart failure, you're more likely to have no blockage in your coronaries, and heart failure actually progresses faster. So it is not uncommon. A lot of these patients have also had hypertension for a while, which is sort of right down Dr. Johnson's alley. So heart failure is a condition that a lot of people do not think about. Actually, I think we have 3 pandemics. The first pandemic is systemic racism. The second pandemic is heart failure. And the third pandemic is COVID. But what we're seeing is that COVID ripped off the Band-Aid, and we saw all the other pandemics come out at once.
Thank you, Dr. Alonze. And I think what you said, you hit it right on the nail. It ripped off the Band-Aid. And I think the fact is that the Band-Aid was holding the health together for too many people in our community. When we talk about heart failure, another common thing that we hear about is people may say AFib. We may say atrial fibrillation. We may say irregular or a strange heart rhythm. And Dr. Ayinde, of course, I'm going to bring you in here. You're our electrophysiology expert on the panel. Talk a little bit about what exactly that is, because we've seen the commercials. There's these devices now that apparently can tell you if you have an irregular heart rhythm. What can you tell us about atrial fibrillation that every person should know?
So atrial fibrillation is, so believe it or not, let's start with the heart is powered by electricity. So the heart generates its own electricity. There are cables that generate and conduct electricity in the heart. Atrial fibrillation is a disorder where, think about it like it's just a lot of generators in the heart that just become chaotic. So it comes from usually the top left part of the heart, and it's speeding up at about 400 beats a minute. Luckily, not all those abnormal beats go down to the bottom of the heart. The bottom pump is the main pump of the heart. Say about when you're in AFib and the top part of your heart is going at about 400 beats per minute, the bottom part of the heart will go at maybe about 120, 130, or maybe slower, or a little faster. But the point we should know about AFib is people feel symptoms, different symptoms. Some people may just feel tired, out of sorts. You may feel your heart beating irregularly, or you may just become out of breath, or you may not actually have any symptoms at all. Now, why does AFib actually matter? That's because when you have atrial fibrillation, you have an increased risk of stroke. There's an increased chance that the inflammation that's driving AFib will also lead to production of blood clots inside the heart that can go to the brain and cause a stroke. So that's why it is very, very important to diagnose atrial fibrillation. If you have AFib, you need to talk to your doctor about preventing stroke. That's the #1 goal. The second goal will be controlling your symptoms, whatever the symptoms are. Now, the final thing I'll say is that AFib is very much associated with age. When people around the age of 40, the prevalence is about 2.3%. By the time you get to 60, 65, the prevalence goes to about 6%. In fact, most of, like about 70% of the population in AFib in the United States right now are within the ages of 65 and 85 years. So it's a disease that's actually goes up with age. And I will encourage everybody, if you have, we all have smartphones now. If you have a smartphone, monitor your heart rhythm. There's a lot of smart watches out there. There's Fitbit Sense. There's the iWatch. Samsung has it. So get a smartwatch. Check your rhythm. If it suspects that you have AFib, talk to your physician.
Thank you, Dr. Ayinde. These are very, very excellent points. I hope people are taking notes. Again, if you have questions for the panelists, please put those in the chat so we can get to them very quickly. Dr. Johnson, I'm going to bring you in. Let's shift the conversation and start talking about where we are currently in the COVID pandemic. And I'm gonna bring some other of our panelists in. Right now we are about 2 months into the rollout of the COVID-19 vaccines, right? We've seen them across the country. We know that some states are doing extremely well, some are not. Some of the recent data that came out about race and ethnicity really were showing that maybe only about 5% of the individuals who've received the vaccine so far are in the African American community. Mm-hmm. Can you talk a little bit about that, just from the aspect of knowing how COVID-19 has affected our community, how COVID-19 has affected those who have things like hypertension and heart cardiovascular disease that's also in our community, and why these individuals may or may not have access to the vaccine or may be considering it?
Okay. Well, first of all, let's kind of take those little pieces in chunks there. The first piece I want to attack is the fact that, first of all, access we know is a problem. In fact, if you want to think that the access is not a problem, it was important enough for the president to actually have a diversity, or if you will, a disparity, if you want to call it that, team to address health disparities and why there are major differences between African Americans and non-African Americans. The second point that unfortunately is still an evil menace to the taxi African American community, of course, is distrust of the medical community sometimes. We have to go back to Tuskegee. We have to go into other situations where governments have been trusted. We can think about more recently a situation with water in Flint, Michigan, where people were told that there was no big deal, nothing going on with the water initially. And of course, we know how that story ended. So the COVID-19 vaccine has already been told, you already heard spoke of already this evening, I should say, was the Band-Aid was removed. Now, one of the things that happened when the Band-Aid was removed, of course, people know that I'm into hypertension. Well, hypertension, what it does is it affects the vasculature very significantly. The COVID-19 virus does. It affects the vasculature. We now know the blood vessels almost as much, if not more, perhaps, depending on how much more data we get, than even the respiratory system. So we know that the COVID-19 virus, as you will get into the walls of the blood vessels. So if you have a group like African Americans, where the rate of hypertension is so much higher than non-African Americans, and hypertension starts the train, unfortunately, by damaging the inside of the blood vessels, the so-called endothelium, if you will. It's not surprising that you have a true tsunami going on when you think about it. Less access to the vaccine, distrust of systems that always provide vaccines, and a high prevalence of a disease state, i.e. hypertension, which can damage the blood vessels and put an already difficult situation, i.e. a COVID-19 infection, and make it twice as severe and twice as deadly, if not more. So we have to keep in mind that as we look at this pandemic, we got to keep in mind that the overall impact on the African American community was more severe, yet the incident, the actual issuing, if you will, of the vaccines is actually severely lacking. So we truly have a tsunami when we think about the COVID-19 vaccine, and we think about the African American community, which of course is most in need. Thank
you, Dr. Johnson. I see a comment from the audience, we're going to get to that comment really quick because I want to bring in Dr. Alonze here. Dr. Johnson just outlined some of the challenges that we're seeing. And, I'm sure many of your patients, as many of our patients, are also high risk, And so when we think about the vaccine rollout, what do you say to your patient who is hesitant? Of course, we want to say that there's a reason that people should be hesitant about new things, right? We don't want to diminish concern, but how do you help them understand maybe some of the benefits?
Yeah, so Dr. Nye, that's a really, 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 really important question. At this stage of the pandemic, we found out early in the pandemic that our people of African ancestry were carrying a disproportionate burden of the disease. I want to take us back to the representation in the two pivotal trials of the COVID vaccines in the US. In the Pfizer vaccine, about 9% of the patients were African American. In the Moderna vaccine trial, which was predominantly done in the US, it was about 10%. So when I see my patients, I tell them that the vaccine is safe. If you look at the data for the Pfizer vaccine, there were about 36,000 patients. The Moderna vaccine had about 30,000 patients. And out of all those patients, the vaccine efficacy rate was 94.5% for the Pfizer and 95 for the Pfizer and 94.3 for the Moderna vaccine. These vaccines are safe. Out of all the 30,000 plus patients, no one died. No one who got the vaccine got severe COVID. The most that we saw was some aches, myalgias, and arm pain. The vaccine is safe. I got my second shot of the vaccine on Friday. Actually, I had a better experience with the second dose than after I got the first dose. We have patients who have had transplants. And I tell them that when the vaccine comes out, you should get it. Patients who have severe heart failure, I say, yes, get the vaccine. Patients who have left ventricular assist devices, I say, get the vaccine. The only time when I would recommend against getting the vaccine is for patients who have had a known allergy to a component of the vaccine. But the vaccine is safe. I know there have been issues with people asking me, the patients who received the vaccine, did they look like me? And I say the answer is yes. The Moderna vaccine had money from the National Institute of Health, and they were mandated to enroll patients who represent the population of the United States. 10%. And there was no, if you look at the plots, there was no difference in efficacy. It wasn't less effective in people of African ancestry. It did not matter what your age was. Paradoxically, we actually saw that patients who were older, who you would think would get a less immune response, had very robust immune responses. So if you're older, if you're younger, if you're African American, Caucasian, everyone listening, I would say, what are you waiting for? Go get the vaccine.
Thank you, Dr. Alonze. And I know that all across the country, healthcare workers were some of the first individuals. And so I saw a question earlier that popped up that said, how many of you have the vaccine? And I don't want any HIPAA violations, but, if you want to volunteer, I would say I had the vaccine. I had both of my doses of the Pfizer vaccine. Anyone else want to just wave your hand if you also had that experience? And Dr. Alonze spoke about that.
I had the two vaccines, yeah.
Exactly. So yes, everyone on this panel has been vaccinated, and I tell you, I feel good about it. Every day, I feel good about it. All right, so let's get another question from the audience. Shonda, I saw an earlier question. Shout out to Shonda, our producer in the back. An earlier question that says, what do panelists recommend to maintain a healthy heart? I'm going to send this to you, Dr. Ayinde. If you can talk to us a little bit about what we can do to really have a heart healthy lifestyle.
Thanks for that question. Well, most importantly, it's basically food and exercise. There's been a lot of change in what's good food, what's not. But what we know is low fat food is actually been shown recently not to be the best, because low fat was being replaced by high sugars. So the best food is food that's low in low in saturated fats, that's high in unsaturated fats, low in trans fats, food that's low in sugars and low in salts. Also, you want to eat a lot of fruits and vegetables, and you also want to exercise. Keeping, exercising at 3 times a week. And I mean, whatever you do, just, people have different exercise tolerance, but just keep your body active. So avoid smoking. Alcohol is not good for the heart. We used to think, 2 glasses and all that. Alcohol is not good for the heart. So avoid alcohol, avoid smoking, low fat, low carb. Just try to balance the low sugars, high complex carbs, and see your doctor every when you're young. You start with, it could be every year. You get your physical, check your blood pressure, check your cholesterol. If you have any family history of high blood pressure, diabetes, screen for that too, and try to keep you, do not gain weight. That's the final thing. Try to cut weight.
Thank you. Those are excellent points. And I think, sometimes people feel like doctors are only pushing medications. But as Dr. Yinde just outlined, just because I give you medication doesn't mean I don't want you to make some changes, right? So nutrition, lifestyle, exercise, weight loss, obviously that's one of my specialty areas. Those are all important in having a healthy diet. We had another question that came up. I'm going to put you on the podium, Dr. Branch. Here we have a message. When would you recommend someone who had COVID-19 re-enter an exercise program given if myocardial involvement, meaning if they had an effect on their heart from a COVID-19 infection? When can they start exercising again?
I believe that question was from my mother. Of course, it was a hard ball. I don't know if we have all the data yet. So if a patient has had COVID-19, I think certainly we'd want to start with an EKG. If they've had symptoms of heart failure, certainly we want to get an echocardiogram. If everything sort of checks out, they don't have any signs of any myocardial injury, their EKG is completely normal, I think it's reasonable to start them back in athletics. But again, I think there's a particular protocol. And if I did have an athlete, I'd have to review the protocol to see, what's the safest thing for them. But I think it's, the biggest thing is going to be their symptoms, their risk factors for cardiovascular disease. This is a very young, healthy population. So, if they had evidence of myocarditis, there was a JAMA paper that looked at athletes after 53 days. And some of them, I think 15% did have some evidence of either acute or evidence of sort of myocarditis within their during their infection. So there's certainly a risk of that. And if someone has had a cardiac MRI, certainly you'd want to evaluate that before they go back to sports. And if they had myocarditis but they're recovered, I don't think there's any reason to restrict them from any athletic competition as long as, again, they're not having any heart failure symptoms. So I think it's a case-by-case evaluation, and if everything checks out, it's most likely to be safe, but certainly you want them to follow up and have some surveillance as an outpatient. But I think we're going to learn more about that.
Thank you, Dr. Branch. And I think you hit it right on the head as it being a case-by-case basis, right? And so, every time we say, can I get back to X, the best person to start with is your physician who knows your case and can do the necessary evaluation. We have another question that has come in. Do any of you recommend a plant-based diet to patients? Why or why not? And then there's a second question of what are some of the barriers your patient face to eating healthy? And are there programs you recommend to guide patients wanting to explore a plant-based diet? So let's go to Dr. Johnson on this one. There have been some evidence coming out about the benefits of plant-based diets, particularly around hypertension. Can you talk a little bit about that? And we can hear you, Dr. Johnson.
There we go. I got you. All right. This really has become a revolutionary movement. It's taken on a life of its own. The idea, of course, being that if you stop and think about fat, let's use that as a simple example. where does fat come from? And we got to be very realistic in terms of talking to, I know an audience of large proportion of which is African American. We can take a vegetable and turn it into fat, right, by cooking it in fat. So one of the problems we've had is even when we get exposure to vegetables, plant-based diet, if you will, we can still cook it in animal fat and wind up with the same bad end results. So I think we all know now that the data is emerging very quickly, and it's becoming more and more now being accepted in many circles that plant-based diets are indeed a good way to go when we start thinking about cardiovascular disease. And of course, the second part of the situation is we know that there are a lot of barriers to plant-based diets, some of which I already touched upon already, meaning that, remember that for people who own supermarkets and people who own places within many times communities of color, we have to keep in mind that the people in these communities, unfortunately, particularly if they're lower socioeconomic communities, will often have a situation wherein they want to bring in the food products which bring about the quickest sales, but all these the ones, of course, would have a long shelf life. Things that have a long shelf life often have what? Preservatives. And the more you take a plant-based diet and put it in a situation where you start adding artificial things to it, whether you be cooking in fat or adding preservatives to the plant, then you know you're going to decrease a lot of the benefit you get from the plant-based diet. So that gets at one of the questions which someone asked about what are the barriers to moving towards a plant-based diet. And one of them is just having access to good, healthy plants. And you have to keep in mind, too, that when I say access to good, healthy plants, I'm also talking about a situation where the plants have to be properly prepared. They've got to be clean, because remember, in any situation where you don't have good sanitation, you unfortunately can introduce another problem into a plant-based diet, which is plant-based diets which are not well sanitized, and therefore, as a result, can spread disease that way. So then you'd have to worry about the infectious portion. So those are the barriers that I see to the plant-based diet. But the concept of the plant-based diet, I think most of us would agree now, is indeed sound. And everybody, I'm finding most of my patients now are doing some variation of trying to increase the plant intake in the overall dietary menu.
One of the parts of that question said, are there any resources that you recommend to patients who are seeking to incorporate more plant-based options in their diet? So Dr. Johnson or anyone on the panel, if there are specific resources you have used.
Well, I guess I'll just say quickly that in terms of resources, one of the things that we have to remember now, particularly for those of us who have internet access, there are several organizations out there, NMA included, where you can go on to the website and find out about different ways that people can increase their access. One of the things which I'm personally kind of hoping to see soar is this concept, which I initially saw when I was at Disney World, believe it or not. They have the concept of growing plants inside of a building, which allows you to use buildings within urban areas and decreases the amount of water that you have to use to grow these plants. One of the biggest problems is that it can take gallons and gallons of water just to grow several heads of cabbage, for example. So if you don't have access to good water, and if the water is partly polluted, I talked about Flint, Michigan a little while ago, if the water is partly polluted, lead-based, whatever, you can't get a healthy plant-derived product if you have an unhealthy source of water. So one of the resources we need to keep in mind when you go online, I'll just name just a few of the organizations. We know we have the National Medical Association. We know they have the Association of Black Cardiologists. We know also we have the American Heart Association. A lot of these organizations will have, if you will, websites which will allow you to get into some of the resources to get more educated about what you need to do from there. And of course, I'm just naming a few, but I'll open it up, of course, to the rest of the panel if anybody wants to chime in.
All right. And we can put some additional resources in the chat if anyone thinks of any later. There's another question. I'm going to bring in Dr. Ayinde here. why are African Americans the least likely to get the vaccine? We talked a little bit about access. We talked about hesitancy, for the history of, the negative effects on marginalized communities. Is there anything we're missing? And what would you say to, leaders in local communities and state communities who want to improve vaccination rates in our community? What would you tell them?
Yeah, this is very unfortunate because African Americans are the most affected. They're the most likely to catch COVID because of the kind of jobs African Americans do, their socioeconomic status, and they're also the most likely to have severe COVID and die from COVID. Unfortunately, African Americans, when surveys have gone out, African Americans are the least likely to respond positively to taking a vaccine. And there's so many reasons. Dr. Lonze mentioned how, there's data out there that shows that African Americans, when they, in the studies, in the Moderna and Pfizer studies, they did as good as Caucasians and other races. The vaccine was as effective in them and did not cause any increased side effects in African Americans compared to other races. I think the big issue is building trust, because like Dr. Johnson alluded to, we've had a big history of systemic racism and unethical research practices, and coupled with this systemic racism, it's made African Americans not just trust the healthcare system. I have a lot of patients, even healthcare workers, who tell me they don't want to take the vaccine. This is very unfortunate. I mean, you have data out there. So I think the big thing is really building trust, getting our stakeholders in the community, local leaders in each community need to come together. And, if I have somebody I respect that tells me that, I took this vaccine and it's safe, if I see that person, maybe it's going to change how my perception about that vaccine. So it's really about getting in the communities and getting stakeholders, important community members, and, trying to get them, try to introduce the vaccine that way, and maybe the perception and acceptance will change.
Thank you. And Dr. Branch, I want to bring you in here as well. When we think about getting the vaccine in the community, but also the relationship that individuals have with their physicians. We know that the National Medical Association has been advocating not just for healthy and up-to-date medicine and information to get to our community, but also for diversity in the healthcare workforce. Dr. Branch, can you talk about some of the benefits of having a physician of color, a physician that looks like you, that knows your experience being involved in your care?
I think that's incredibly integral to care. I mean, it's just like having, a Hispanic physician who can speak Spanish, and you have patients who speak Spanish. I think there's an obvious benefit in that scenario, but I think it may be missed on folks, the benefit of having increased African Americans in the physician workforce. We have a shared culture of vernacular, interest in art, and it's a separate culture, and it's an American culture, but there's also culture within this American culture. And so being able to have a conversation with someone who understands you without even having to articulate what you're trying to say, who's had a shared experience with you, who can explain things in that short sort of 15-minute visit. A lot of times within 15 minutes, if one person's trying to explain something who has had a different experience than their own, it may take a great deal of time that they may not have. But when you can quickly sort of have a quick understanding of what folks are trying to explain to you because you've had those shared experiences, then you can really maximize that limited amount of time to be effective in talking about lifestyle changes and sort of explaining the importance of the vaccine in a particular way. So I think, diversity in the workforce, unfortunately, it really took a dive after the Abraham Flexner report in the early 1900s. You had a lot of historically Black universities that had hospitals that were training African American physicians during this period. And when Abraham Flexner came, you only had left, I think it was Morehouse and Meharry, but there was Leonard, there was Shaw. I have a family member that went to Shaw. It was called Leonard. And so, when you lost that sort of community physician, I think you really lost the community itself. And so I think, it's also going to take a little bit of decentralizing healthcare, or we may have to go back into the community to kind of reestablish that relationship. So it's going to take a lot of work, but I think the AHA, the NIH, and everyone is on board to understand the importance of increasing diversity.
All right. Well, thank you, Dr. Branch, for that. And you really highlighted some of the history behind there, as well as the benefit we know of having a diverse healthcare workforce. So as we come to the conclusion of our program, I'm going to give our panelists about 30 seconds. If there's one thing that you want our viewers to take away from tonight's talk, what would that be? And we're going to start with you, Dr. Ayinde. What was the one thing that you want our audience to take away from tonight?
I think everyone should take ownership of their health. Whatever health condition you have, try to understand it. Talk to your physician, talk to your healthcare provider, really understand, be a part of it. Because I realize that the more patients understand their condition, the better they do, the better they, like a good example. There's this medication called rivaroxaban, Xarelto. So that medication, you take it with food. The reason you take it with food is because there's a 75% increase in its absorption if you take it with food. Guess what? I have a lot of patients who have AFib who take this medication, but they don't know why they take it with food. So sometimes they don't take it, they take it in the morning because they don't understand that I should take it with food. But the moment you realize, I tell them, this is the reason you're taking it with food. They never miss taking it with food. So the point I'm trying to make is understand your health, understand your medications, and take ownership.
Thank you, Dr. Ayinde. Dr. Johnson, what would you say is the one thing you want to make sure that people don't forget after this program?
I think the biggest thing, because we now know, of course, the pandemic is king. So what we don't want to do is to let the first pandemic, you heard it articulated well on this program, bring about more damage from the previous pandemics we had. Let's face it, hypertension and its related disorders that result in more strokes and more heart attacks was already a pandemic in the African American community before this program came on, before 2020 came around. That was already a pandemic. So my take home message is that, remember, knowledge is power, but the application of knowledge is powerful, makes a difference. So be informed, reach out to organizations. We're here to be an example. The National Medical Association, Association of Black Cardiologists, other organizations where people from the African diaspora reach out to people from the African diaspora. So please, African Americans and all others out there who are listening to this program, the take home message is to understand what's going on. And when there's a lack of understanding, make sure there's not a lack of access to information. Get the information that will get you to what you need to know so that you can have access, because there's plenty of access out there that we don't take advantage of. So let's not focus so much on that which we do not have, but let's have a moment which that which we do have and we do have access to, thanks to organizations like this and programs like this.
All right, Dr. Alonze, you're up next. What do you want our audience to take home tonight?
So I want to start by thanking the NMA for bringing together this elite panel of speakers in the field. I think it will be. I think I will be remiss if I did not stress that again, we have three pandemics. Okay, but the pandemic that we're worried about right now is COVID. But I want any listener to know that you should not let the COVID pandemic accelerate the other pandemics, which means that if you have any heart disease of any sort, do not allow the fear of going to access care. Do not be afraid to access care because of fear of the COVID. That's one. The second thing is, if anyone is listening on the call and has any questions, the vaccine is safe. The COVID vaccine is safe. Every speaker tonight has received the vaccine. We are all doing well. The vaccine is one of the most effective ways that we can reduce the disproportionate toll of the pandemic on people of African ancestry. The third thing I want to say is that the COVID pandemic is here. But remember that the COVID pandemic would not prevent you from getting heart failure. It will not prevent you from getting hypertension. It will not prevent you from getting. So even if you don't feel right, it's not always COVID. So just always seek care, whether or not it's COVID. The vaccine is here. There's light at the end of the tunnel. Thank you.
Thank you. And last but certainly not least, Dr. Branch, your final words.
So my final words would be, I think the panelists highlighted this very eloquently in that the effectiveness of the vaccine has been shown to be effective in African Americans as well as Caucasians. At least in the Pfizer study, there was 9% of African Americans within the study, and they did a subgroup analysis to look at each group by age, by race, and there were 0 cases of COVID-19 with the 2 vaccine for Pfizer within the African American group. So certainly it's effective within us, and certainly that shouldn't be a barrier to receiving the vaccine. It has been studied within African Americans. We do know it's safe. So please go out there. My grandmother is 102 and she just got her vaccine. So I think if she has the courage to do so, I think that should encourage everyone else.
Thank you. And I love that last piece. Again, we want you to, if you have questions, who do you talk to? Not Dr. Google. We want you to talk to your healthcare professional. And if you don't have a healthcare professional that you feel you can talk to, then you can look to the National Medical Association, and we'll make sure that you have one that you can, because that's why we're here, to make sure that our community has access to the best medicine and the best healthcare professionals to make sure that they can live and you can live the best life possible. So again, thank you for joining us for NMA Talks. A quick reminder, we want you to be able to tune in to a great program that we have partnered with called Release the Pressure. You can find out more at releasethepressure.org, and you can join them for their National Virtual Vision Board Party on Saturday, February 13th at 1 p.m. Central Standard Time to get their self-care on this Galentine's Day with live music and experts, and of course, folks from the National Medical Association. So go to releasethepressure.org for more information. So again, thank you for joining us for NMA Talks. That's brought to you by the National Medical Association. A special thank you to our expert panelists, Dr. Ayinde, Dr. Lanze, Dr. Johnson, Dr. Branch. We could not do this without them and our membership. So please follow us and connect with us at National Med ASSN, where you can find recordings of this and previous NMA Talks episodes to share with your networks. You can also email us at nmatalks@gmail.com with questions and comments. And be sure to join us for future programs. Until then, I'm Dr. Michael Knight, wishing you a good night. Thank you for joining us.